All right, well, welcome to this month's CME. This time we're going to be talking about pit crew and crew resource management, kind of an organized approach to cardiac arrest. All right, so some of the things that we're going to discuss today is the team dynamics of the pit crew model. We're going to review the updated science behind high quality CPR. We're going to discuss the importance of building a team and delegating upon arrival. And we're also going to review and discuss C1, our medical cardiac arrest protocol. All right, so let's talk about crew basics and positions. We're not talking about our dispatch arrival stuff or anything like that today. What we're talking about here is just once we get on scene of a cardiac arrest, how are we going to function? So the first thing we need to talk about is positioning. And depending on what your makeup for your crew is that day, if you're on a 3-man engine, if you're on a 2-man rescue, if you're on Sunstar and you get there on scene first, how are we going to accomplish what we need to do? So the first thing we need to think about is high quality, uninterrupted CPR. So we'll start talking about position 1, position 2, position 3, position 4, position 5, but we'll talk about more of those as we go along through this PowerPoint. So the first thing we need to start thinking about, like I said, is positioning, high quality, uninterrupted CPR. We're going to talk about compression and defibrillation, and then when we have 3 or more clinicians on scene, we'll start talking about IO access and starting to get the medications going on the patient. All right, so let's talk about what is the most important treatment for a patient in cardiac arrest when we get there. What's that you say? High quality CPR? Sounds good to me. All right, so the first thing we need to think about is maximizing our interruptions. Well, not really maximizing our interruptions, but maximizing not interrupting our CPR. So even a brief pause of greater than 15 seconds of chest compressions has shown to correlate with myocardial dysfunction. An abrupt and profound drops in coronary perfusion pressure, a drop in carotid artery blood flow, and then if we're not doing, and we should be doing rhythm checks or pulse checks for more than 10 seconds. All right, so the science behind high quality CPR has shown that with good end-tidal CO2 and CPR, we should have high end-tidal CO2 numbers during good quality CPR. So we should be able to maintain a range with high quality CPR of 35 to 45. And even with BLS CPR, we should have that waveform capnography, and it should be showing that, hey, we're getting some really good CPR and gas exchange going on. All right, so what you see right now is you see the pit crew model as we have it in our MOMS protocol. So when we look at this, we see that we have a red triangle that's kind of sitting over the shoulders and goes down to the sternum, beyond the sternum to the navel. What that is stating is that, hey, that's our no-fly zone, all right? This is why we don't do humeral head IVs during cardiac arrest. This is why that area is designated for chest compressions only. And the reason we do that is because we have compressor 1 and we have compressor 3, and those two are working as a team going back and forth, and we don't need people in the way of those compressions because that's what's saving lives, high-quality CPR. All right, so let's start talking about these pit crew positions. So this is position 1. Position 1 is going to be a compressor / defibrillator. This can be an EMT or a paramedic certification at that position, and their job is to initiate uninterrupted compressions. And when the ability or when they have the time to, they're going to go ahead and attach a monitor. They're going to either attach the monitor, AED, or they're going to start attaching our QCPR. So, big thing here is deliver the shocks if indicated at the conclusion of the first 2-minute cycle, or if they meet the criteria during protocols of being on scene less than 4 minutes after a patient has had a witnessed cardiac arrest, then go right to a quick look on the monitor to see if we can do a defibrillation. They're also going to continue providing uninterrupted high-quality compressions, alternating with the position number 3 and verbally announcing all the rescuers. So they're verbally announcing to all the rescuers so they're prepared for switching compressors. All right, so we've talked about position 1, so let's talk about position 2 now. Position 2 is going to be our airway ventilation. This is going to be a paramedic if available during during ALS. During BLS, it's going to be an EMT or a paramedic. Their job, open and clear the airway, position, ready the monitor, put the AED in the initial, and start the AED and start their initial cycles while the compressors starting their initial cycles compressions. They're going to attach O2, end-tidal CO2. They're going to provide ventilations with the bag valve mask at the appropriate ratio for the number of rescuers. Okay, So we talked about position 1 and position 2. Let's jump into position 3 here. So position 3 and position 1 are very similar in nature. It's going to be your compressor or defibrillator, depending on their qualifications and skills. If present during the initial cycle, they can also assist position 1 by attaching the monitor, getting the AED on, getting the QCPR out, and they can also initiate the uninterrupted compressions following initial rhythm, pulse, checks, and shock delivery. They're also going to be delivering the subsequent shocks because they're going to be located in the alternate position with the other compressor. They're going to continue providing uninterrupted, high-quality compressions, alternating with position 1, and verbally announcing to all rescuers that be prepared for the switching of compressors. So at every 2 minutes, they're going to be talking about switching. All right, so we've gone through our positions 1, 2, and 3. Now we're going to move into positions 4 and position 5. Position 4 is our vascular access and our meds. This needs to be a paramedic. They're going to be establishing an access with an IO, or if they're unable to access an IO and the patient has an indwelling catheter, that's a possibility of using, or they're going to try to obtain an IV. They're going to be administering medications as indicated and per protocol for a cardiac arrest. They're also going to be assisting with other ALS procedures as needed. And remember, that person that's down there at the leg is going to be that person that's going to be initiating all the IMACs, which we talked about before. So make sure that when you are in that position that you are announcing what medications you're giving and you are verbally getting a confirmation from your crew that this is the appropriate medication for this patient. All right, so now that we've talked about the positions that we need to effectively work a cardiac arrest, we need to add that 5th position in there. That 5th position is going to be your documentation, family liaison person. It could be an EMT or paramedic. It's usually going to be an officer or some type of supervisor that's going to be on scene. Their job is just to gather and document patient information and pre-arrival stuff from the family. They're also going to try to do some of the bystander interviews, and if they need to, they can actually perform some interventions. They're going to be document the EMS care provided on the EPCR, and if possible and situation allows, provide the family with some updates. They're also going to be maintaining that overall situational awareness and prepare for transport, logistics, and all that great stuff that they need to do by bringing boards in, and making sure that with patients being transported to the appropriate facility. All right, let's take a look at the bag placement for pit crew. So we've discussed where all the personnel need to be. Now we need to discuss where all the equipment should be to make this run efficiently and smooth. All right, so up by the head, what do we need? We need to have a suction unit, we need to have the MRX or a cardiac monitor, and we need to have the airway bag, right? The monitor needs to be positioned in a fashion to where everyone has a view. The only person that may have a difficult time seeing it might be the airway person, but we still need to try to do the best that we can so everybody can see the monitor, which the reason we do that is because of our IMAC, and we want to make sure that we are providing the appropriate joules if we have to defibrillate a patient, and that way everybody can be involved in the IMAC. Down by the feet, we're going to have the med bag. The med bag is going to be right by the paramedic who has established the IO. And once again, as that paramedic is drawing up medications or about to give medications, they are confirming prior to administration of those medications that it's the proper medication and that everybody is in agreement with that medication and there's no contraindications to giving it. All right, so we got all of our personnel in place, we got our bags where we need them, our monitor where we need it, our suction unit where we need it, and we're doing high quality CPR. So let's just do a real quick review on exactly what we talked about here. First thing we need to remember is the first 2 rescuers on scene need to focus on high quality CPR. Don't worry about anything else, just high quality CPR. That's what's going to save their lives or give them that chance of getting Ross back. They're also going to try to place the pads on the patient and defibrillate if indicated. They're going to get the QCPR in place, and as additional rescuers arrive, they'll fill in those positions and we'll move from that BLS high quality CPR to ALS high quality CPR and start administering some medications and establishing some advanced airways. Okay, so we talked about the pit crew model, but now let's kind of switch gears here and kind of talk about our crew resource management. So in the pit crew model, crew resource management is paramount. There needs to be one leader. Everybody has a say, but we need to have one person that's kind of running things so we don't have a whole bunch of different ideas being yelled at one time. that person needs to be using closed loop communication. So in other words, if I'm asking somebody to do something, I want them to repeat back what I just told them to do and confirm that that's what they're going to do. We also need to make sure that we're IMACing everything. That intervention, medication, administration cross-check is paramount. We've talked about this before. Medication areas, not medication deaths or procedural deaths in the country, 9.5% of deaths. It's third in the nation behind cancer and heart disease. That is kind of ridiculous in my book. There's no reason that patients should be dying because we're giving them the wrong medications because we are failing to do IMACs. So make sure we're getting those IMACs done on scene before we're giving medications or before we're doing high-risk procedures so that we can avoid these errors. Like I was talking about with CRM or crew resource management, everyone's got to be involved in it. You know, if you see something, say something. You need to speak up if you see something that's not going the right way, or you see something that maybe the team leader hasn't seen. You know, feel free to let them know, hey, listen, I think this might be going on and maybe we should try this route instead. Also, you know, one of the big goals of crew resource management is just keeping our timestamps right. You know, making sure that, hey, we're getting things done, we're giving those medications, we're giving the epi every 3 to 5 minutes, you know, we're following up with 2-minute cycles, we're doing less than 10-second rhythm checks, and that's going to keep us on par for having good outcomes on cardiac arrest and making sure these patients have a chance of getting ROS back.